Hi guys. We are going to go find Dr. Beverly Joyce. See if she's there. It worked.
Hello.
Hi. Long time no see.
Long time no see.
Hi. Hi. Welcome to the Instagram Lives
Thank you.
of HotPause Health.
I have my little friend who has pink hair like me now. Do you love her?
Oh my God. You seriously are making my day.
Okay,
Yes,
good.
you
That was
are.
the main point,
I
right?
know. These things bring joy. They really
Yes.
spark joy. They crack me up.
Joy is absolutely necessary
Well,
in every day.
you know a lot about joy, and we're going to talk about some of the books that you might have written. Just saying that
Yeah,
might
just
have
one.
joy. Just one amazing book.
Yeah.
Okay, well, people are joining. This is so exciting. I'm going to wave to everybody. Hi guys. So exciting. So we're going to jump right in with one of my favorite humans who has been on the HotPause Health journey since day one, and we are so grateful to not only have her as an advisor, but as a trusted friend and just all around amazing human who um, really brings such confidence and clarity. And as we spoke about earlier today, resolute. I mean, you one of those people you're like, I believe you. You were so clear, and we're so grateful for your opinion and perspective. So, before we dive in, do you mind if I give you a quick bio?
Sure.
Okay, because I feel like setting the stage on who you are is such an important part of the gazillions of questions that we have ready and waiting for you.
Yes.
Okay.
Yes. And my identity has changed over the past probably 15 years from obstetrician to gynecologist, menopause specialist. So feel free to go ahead.
Okay. So we are joined today by board certified OBGYN, Dr. Beverly Joyce, who is currently in practice right now at Stanford University and has spent 30 years, folks, yes, 30 years helping and supporting thousands and thousands of patients from their infertility journeys to delivering babies, including mine, um, to postpartum, um, to menopause and that perimenopause transition and everything in between. And as Dr. Joyce just mentioned, she really, I think you had this epiphany, which we can talk about, but you had a transition and you went from obstetrics and delivering all those beautiful babies to really focusing on this second chapter of a woman's life in perimenopause and menopause, particularly inspired by your own perimenopause and menopause journey, which sparked new challenges and new conversations. But it also led, and I do want to point this out, is that you wrote a book, which if you haven't read it, I've read it. I cried all the way from Hawaii to California, and everybody was watching me cry on the plane, but it really is, it's an incredible book. And so it is called The Birth of Joy. I'm going to read the whole title though. The Birth of Joy, a female physician's healing journey through childhood trauma, midlife burnout, and the rediscovery of passion and purpose. And I think it doesn't matter that you're a physician. Clearly I'm not a physician, but it just resonated so much with me. So I'm so grateful that you wrote that book. And we're also so grateful that you are a HotPause Health advisor. And so I think we're going to jump in. But before we do you want to say anything about how menopause, maybe your own menopause journey kind
Yeah,
of supported what we're talking about today?
absolutely. So, I mean, it kind of ties into the book, but basically, the whole reason why I stopped doing obstetrics was what I thought at the time was just burnout, because basically, my practice model with my partners was we all delivered our own patients 24/7. So, even though there was a call rotation, if one of my patients came in on a day when I wasn't on call, they would still call me. And, at the time, I had teenagers, and I mean, it was just craziness. But what I discovered later down the road, after I had already made the transition, was that I was also in perimenopause at the time, and I didn't know it really because I was on continuous birth control pills. And so I thought all of my rage and my, irritability and all of that was just due to burnout when it actually had a lot to do with hormones. And so when I kind of figured that out, that was when I decided, oh my God, if I don't know this stuff and I'm a trained OBGYN, then how do I expect my patients to navigate this phase of life? And so I did the NAMS, the North American Menopause Society, now known as just the Menopause Society, um, certification. So now I actually have certification in menopause management, and patients are seeking me out for that purpose. And I describe some of that in the book, along with my growing up and how I developed the perfectionism and the imposter syndrome, and how I became a physician coach, and a whole bunch of other stuff that people can read about if they so choose.
Well, and
So thank you.
I think that so much of what you went through as just a woman, but that rage, that anxiety, and you didn't even acknowledge it, even though you had training for years and years and years and thousands of patients coming through your door. And you went to Hopkins, you couldn't have had a better training. And yet it's right in front of you. And so many of us don't even know that it's happening.
Yeah.
And I think that that's where, the conversation that we're going to have today, we get so many questions from women who feel like they're going insane and they want help, but they don't even know where to start.
Right. And
So,
they get sort of poo-pooed, and internists who don't know a lot about this phase of life will say, "Oh, well, if you're having regular periods, you're not in perimenopause and it
mhm,
can't be hormones."
mhm,
And we all know that that is not quite right.
that's correct. So one of the questions I'm going to dive right in, and I feel like it continues to come up and we continue to write about it, we continue to talk about it, but menopause hormone therapy, or formerly known as, not Prince, but formerly known as hormone replacement therapy, um, is that many women are afraid of it, and in particular breast cancer, which we can go into, and that could be a whole other TED talk that we have. But there's this notion that if I have a family history of breast cancer, I cannot do menopause hormone therapy. Is that true, Dr. Joyce?
So, as with any kind of discussion, there's always some nuance to it. But
Mm-hmm.
the short answer is a family history in and of itself does not mean you can't use menopausal hormone therapy. There may be more discussions to be had around what are your particular breast cancer risks, like if you have dense breasts, if you've had a biopsy that showed some atypical cells. Um, those would be potentially reasons why you might want to not do hormones, because we know that if there are tiny little cancer cells, even if we don't see them on
Mm-hmm.
mammogram, that if we give them hormones, they can grow and then they become apparent. What we do know, though, is that if you take menopause hormone therapy, it doesn't cause de novo, new, out of the blue, nowhere breast cancer.
And I also want to qualify here is that we're going to be having these conversations. This is not medical advice. It's not Dr. Joyce giving you medical advice. It's not HotPause Health giving you medical advice. What it is opening up this conversation and empowering you to have a conversation with your provider and saying, hey, I heard that even though my Aunt Linda had breast cancer, that I might be a candidate. And, this is new information for me. So I just want to call that out.
Right.
Okay. So if you have a history, net is check to see if you have contraindications, but for most women, it is an option.
Absolutely.
So,
And there may be other options besides hormone therapy
right.
that we also
Yep.
discuss.
Exactly. So one of the questions that we often get is this notion around language, and language matters. And people get hung up around certain language, and bioidentical comes up.
Mm-hmm.
And it's this like, well, what is it? Does it matter? Is it better? Is it worse? Do I have to avoid it? Should I only seek that out? And can you explain what does bioidentical mean when referring to hormones? And what are the implications?
So, little history. It used to be Premarin was basically the only estrogen product that was given to women, back in the 70s, and it was made from pregnant mare's urine, hence the name Premarin.
Primary.
And Provera, medroxyprogesterone acetate, was the progestin that went along with those. Those compounds are not found in human bodies. So the compounds that are found in human bodies are estradiol, estriol, estrone. Those are basically the three estrogens, and progesterone and testosterone. These are all hormones that are made by the ovary in the human body. So that's what bioidentical means. But the term itself was actually coined by some marketing people to promote their compounded hormone products or pellets or whatever, to sort of get a part of the market that was looking for something that was considered more natural. So we now have tons and tons of FDA approved, perfectly known to be quality controlled bioidentical products. So
Yep.
estradiol, estradiol patch, estradiol cream, estradiol gel spray, progesterone. We have micronized progesterone. We have testosterone gel. That's a whole nother topic as it pertains to women. But that's what it means. Bioidentical means it's what the body makes.
And so, and I just want to double click into this because I think this gets confused a lot where people say, well, I don't want to take anything, I don't want to take a prescription or a drug. And when we talk about menopause hormone therapy, your body's already making it. So these molecules are just mimicking exactly what your body makes, I think.
Right, in much lower doses, I'll have to say,
Yeah.
in menopause than, say, in pregnancy.
Yeah.
So, I mean, this is a whole nother discussion
Right.
about, the levels of hormones that are in the body. But estradiol levels are super high in pregnancy. Progesterone levels are very, very high in pregnancy. And what we're giving people at menopause is much, much lower doses.
Well, and I
But
also I like to say to people, vitamin C, for example, they're not squeezing oranges and making vitamin C. These are molecular, these are just molecules. Or aspirin, right? I mean, aspirin is willow bark. It's a molecule. They're not doing willow bark and putting it into your aspirin. So it's just molecules that mimic, the same
right.
thing.
Yeah, we're not grinding up
We're
ovaries to
not
get
grinding
the hormones out of them. We are actually synthesizing these molecules. They just are the same,
the
if
same.
you look at their molecular structure, as what the
Yeah.
body would make.
So I think another confusing, or not confusing, I think a really interesting conversation is around progesterone. And particularly my friends who have insomnia, please tune in right now, is what is progesterone and what are the implications of when it starts to decrease in perimenopause, and why does that matter?
Ooh, that's a very good question. So progesterone, if you break down the word, it's gestation, own, just the hormone. So it's the hormone that basically supports pregnancy. It is produced after ovulation occurs. And if that egg is fertilized and someone becomes pregnant, then their progesterone levels rise. If the egg doesn't fertilize and the period comes, then the progesterone drops. So, it fluctuates greatly going along with
Your cycle.
ovulation.
Your cycle.
So, exactly. So, when in perimenopause, you start having just wacky doodle periods, that's usually because ovulations are happening either not at all or less regularly. Sometimes you can ovulate twice in a month. Sometimes you ovulate none times in a month. And so the progesterone is all over the map. Hence, the bleeding is all over the map too.
Right.
Yeah. Now, when we give women menopausal hormone therapy, estrogen is usually what will help their symptoms, the vasomotor symptoms that we know of as hot flashes, night sweats, and lots of other things that happen in the body due to lack of estrogen. But if you just gave somebody estrogen by itself, their uterine lining would build up. And so we don't want to give women
Just
uterine cancer So we don't want to give them just estrogen, exactly. So we give progesterone. Its main purpose in menopause hormone therapy is to prevent or to control the uterine lining building up.
Right.
But what we know, to your point, what you alluded to, is that it also is sort of a muscle relaxant, and it also helps women with sleep. So in hormone therapy, we give women micronized progesterone at bedtime to kind of help with that part of the problem.
Yep. So, friends of mine who have been on menopause hormone therapy talk about the patch, obviously, but the sleep changes that many experience once they go on progesterone is game changing. And so, certainly something to think about if you are experiencing insomnia. So, the next
Absolutely.
one is one of my other favorite hormones, testosterone, which you and I have had extensive conversations about. But because we have over time begun to gender our hormones, estrogen female, testosterone male. I think a lot of women don't realize that testosterone, that we produce testosterone as women, and that is a fundamental, one of the most fundamental layers of having, our bodies require it, it needs it, and there are impacts when our testosterone begins to get low. Would you explain what the importance is of testosterone for women in particular?
So testosterone is produced in the ovary in about 1/10 the amount of what men
Mm-hmm.
produce. And a lot of women will feel better with testosterone. They feel more sort of joie de vivre with testosterone. Um, it helps with building muscle, it helps with bone, it helps with libido. So all of those things are reasons why someone might want to have testosterone.
Mm-hmm.
The caveat is that, as your ovaries stop producing estrogen and progesterone, they don't stop producing testosterone. So I don't think it's the only kind of game in town for libido, for
Yep.
instance. Um, for women who, for whatever reason, have their ovaries removed or they have ovarian failure, what we used to call premature ovarian failure, now it's premature ovarian insufficiency, that's where the ovaries really do stop making everything, or you've removed them, so there is no estrogen, no progesterone, no testosterone. Those women benefit greatly from adding testosterone to their hormone regimen. I will say there are some women who have already high levels of testosterone.
Mm-hmm.
For instance, if you have polycystic ovary syndrome,
Right.
if somebody like that presents with complaint of low libido, we really have to measure their testosterone before we give them testosterone. I would
Right.
say that across the board, but women who already have high levels of testosterone, you're going to be a little hesitant maybe to give them additional testosterone. And there are some risks if you go too high with testosterone levels.
So, which leads me to my next question because it continues to come up. I mean, I'll be at a dinner party or a cocktail party, and someone inevitably brings up pellets. And I think it's important for, again, women to understand options, but also understand risk benefit, and would love your perspective on pellets and their impact.
Yeah, so pellets are basically compounded estrogen, estradiol, and also testosterone typically that is injected into the fat, usually in the buttocks, and dissolved slowly over the course of about 3 months.
Mm-hmm.
Um, so I think a lot of the people who promote pellets and do pellets are telling women this is bioidentical, which we talked
Right.
about, and super easy, which may be true. Um, the downside is that if you have some complication from a pellet, so for instance, say you develop breast cancer, not as a result of the pellet, but just,
Right.
separate from that.
Coincidentally. Right.
Yep. Now you have this added estrogen in your system that you really shouldn't have. Or sometimes testosterone levels I've seen are supra physiologic, meaning they're way, 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 way
Mm-hmm.
higher than what is normal for women's
Right.
levels. And you can have enlargement of the clitoris. You can have growth of an Adam's apple. You can have lowering of your voice, which, by the way, is permanent, not reversible.
Oh, interesting.
And you can
You
have facial
permanent?
hair. You can have acne.
Huh.
Yeah, yeah.
Interesting.
So, um, I, in in my own practice, I don't do pellets. I'm not an advocate for pellets. If someone says they want pellets, I try to discourage that
Mm-hmm.
because we have FDA approved products, plenty of them that are available and they're inexpensive. They're mostly covered by insurance, which pellets are not. Um, and so it's a far safer way to go for menopause hormone therapy.
So just to be clear, there are testosterone versions of a non-pellet that women can use
Yes.
that are transdermal that would have the same effect without some of the complications or potential risks of a pellet.
Yes.
Okay.
And the bugaboo is that there is no FDA approved product for women. There are plenty of FDA approved products for men, as there are for erectile dysfunction, tons and tons, and very
Mm-hmm.
inexpensive, but we won't go there. Um, so we do prescribe the gel that is meant for men to women, but we adjust the dosing by about 1/10.
Yeah.
So they don't need as much as men, obviously. And then we do follow levels. So people who do pellets oftentimes will tell women, "Oh, we have to follow your levels every three
Right.
months." We don't need to do that for estrogen, but you do need to do it for testosterone.
Yep. Okay. Thank you. So we're doing a deep dive on all things treatments. And one of the questions that I know you get in practice a lot is whether or not there are treatment options for, and you mentioned it earlier, rage, some of these mood
Mm.
swings that some of us may or may not have. And are there are there ways for women to get help that you would recommend them begin to explore and understand what their options are?
Gosh, it's a hard one because, if we could just give somebody menopause hormone therapy and fix their irritability and their rage, that would be a
Yes.
miracle. Unfortunately, it doesn't exactly work that way. Now, some women will benefit from an antidepressant or an anti-anxiety medication, like an SSRI. Other times, women can deal with the kinds of mood swings and stuff with mindfulness, with meditation. I think the first thing that often helps is just to tell people, especially your inner circle, listen, I know I'm this way, and please forgive me if I jump down your throat or whatever. So a lot of self-reflection can help with that and doing some mindfulness just around that. The other piece, and this kind of ties everything together, is sleep. So certainly if you're not sleeping well, if you're up 2 or 3 times a night, I've had women who tell me, I'm soaked and I have to get up, change my pajamas, change my sheets before I can go back to the bed, and then I can't get back to sleep.
Right.
So, as it pertains to rage and irritability, if you're not sleeping well, you are just on a much thinner ice, and it doesn't take much to kind of get you over the edge.
Yeah, I feel like it goes back to those baby, that fog of war in those first, call it 1, 2, 3, 6 months of having a baby for those people who have, where you're just running on fumes. But the problem is you can't run on fumes for a third of your life. That just
Right.
won't really work. So
Yeah.
how do you begin to find the tools to help you support getting that sleep? I mean, we hear it time and time again from, one of our other medical advisors, Dr. Kin Yuen, that sleep medicine and sleep health in women is obviously under researched, but that they understand the importance of sleep in overall longevity, and life. And so I think it's a great
Yeah.
call out.
Well, and that
So that's,
was the other thing as it pertains to my situation was doing all those deliveries on days that I wasn't on call. Either I was just on edge and anxious because I thought at any moment I could get called, or I do get called, and a lot of times it's in the middle of the night. As you know, babies don't have a
yeah,
time clock. They come whenever they want, and they like to come in the middle of the night. And so I could be up 3 or 4 nights in a row and still have to function. And so that was part of the burnout piece and the perimenopause piece together.
yeah. So I think the next question, which is basically the same question, which is, are there treatment options for women as we think about cognitive changes like brain fog, or I feel like I'm looking for a word, I'm looking for a word. or I forgot to spell a word. I mean, weird words that you're like, I know I know that word. And you look
And
and
you're
you're
like,
like, that
"Hey,
can't,
it's on the tip of my
like,
tongue."
it's so bizarre. The other day I forgot my zip code. I was, I literally was like, what's my zip
Wait a
code?
minute, where do
Nine.
I live?
And it was like, I thought I was losing my mind. I mean, I was losing my mind. Are there things for women that could help from a therapeutic and or lifestyle that you've seen really impactful?
Yeah. Yeah. First of all, just to reassure people that this is not permanent. So there is a dip in cognitive function that we definitely see in perimenopause, and it's very specific. It's what you mentioned. So it's in these frontal lobes of the brain that deal with memory, and it's word finding. It's, knowing people's names. It's multitasking.
Yeah.
So I kind of call it the ADD of menopause because it seems like that, or at least it seemed like that for me.
Yeah.
And I can't remember where I left my keys. I lose my phone all the time. I'm like to my husband, can you call my phone? I don't know where I left it. Um, so it does improve, but in terms of what we can do therapy wise to help with it. So going back to sleep, if you're not sleeping well, it definitely impacts on that. So we always work on sleep. Exercise. Exercise is fundamentally good for the brain because it gets oxygen to the
Yeah.
brain. And the more oxygen to the brain, the more those neurons fire. Um, Good nutrition, making sure that you are
Yeah.
eating a balanced diet, that you're getting plenty of your omega-3s and all of your vitamins. And it's better if you can to get those through food rather than supplements, but supplements are certainly available. And then there are some other kinds of things that sort of may help. So we know creatine is one of
Hmm.
the sort of supplements that women use to kind of help build their muscle and stuff. We know it helps with bone, and it probably also helps a little bit with brain. Um, Magnesium, particularly the magnesium L-threonate, is one that can cross the blood-brain
Mm-hmm.
barrier, and that can also help a little bit with that. Um, NAD is sort of an area I'm not particularly familiar with, but I know that there is some research into how do you boost your NAD levels because that goes towards making more ATP in your cells
Yeah.
and in your brain. So um, those are the main things that will help with brain fog. And then the other things are just sort of tactical things like post-it notes. Put them everywhere.
I
Yes,
literally have them all over. It's not funny.
lists. Lots and lots of lists. The problem is I lose my lists. Um, having things in your phone that you can't lose, right? Unless
Yeah.
you lose your phone. Yeah, those are tactical things. But I think, there also are a lot of women who are being diagnosed with
Right.
ADHD sort of unknown at this time of life. And is it new onset? Is it uncovered ADHD that maybe they were just, powering through before they didn't know? Either or both of those can be true. So some of the medications for ADHD can be helpful for some of these cognitive changes.
That's Thank you for all that. And then we do have a question here. So the question is, I'm 60 and learned too late about the benefits of HRT. What options do I have for post-menopause, yet I still have complications? And I'll qualify this saying, definitely talk to your provider, but I think this is a great question. It's like, is it too late for me?
Yeah, people think they've missed out, and to a certain degree, they kind of have because it's best if you can start hormone replacement therapy or MHT within the first 10 years of that final menstrual period. So the average age of menopause is about 51.
Mm-hmm.
So if you stopped having periods at 51 and now you're 61, you are still kind of at the end of that 10-year
Mm-hmm.
period, but you could still take it. But it's definitely a nuanced conversation because there are plenty of women who are super healthy. They don't have high blood pressure, they don't have high cholesterol. Some of them do like a coronary calcium scan to look
Yep.
and see if they have any buildup of plaque in their arteries. And if that's zero and you're 65 and you want to do hormone therapy, maybe you have some osteopenia and you're like, well, I want to do hormones as opposed to Fosamax or whatever.
Right.
Um, that is a conversation that you certainly can have, and you go through with your doctor, well, what are the benefits and what are the risks, and then you decide together what is your best option. But there are certain medical conditions where it would not be advisable.
Yeah. But again, I think it's worth the conversation and asking and seeing if it might be something that you could look into depending on what your symptoms are and what your contraindications may or may not be.
Exactly. I mean, you certainly can have the conversation.
Yeah, won't hurt. Okay, last question because I love this question. And this is for all my friends who are listening in right now who are in their 40s. Ladies, Dr. Joyce, can I please understand if I can get pregnant if I'm in perimenopause? But let's say that I have a patch, for example, and I'm taking progesterone tablets. Can I still get pregnant? Do I need to have contraceptives or am I
Mhm.
covered?
You're definitely not absolutely covered. So if you're still having periods, you still could potentially ovulate, even if you're on menopausal hormone therapy. So the levels of hormones that we give in menopause hormone therapy are not the same as in birth control, as in like oral contraceptive
Mm-hmm.
pills. So it does not protect you. It does not prevent ovulation. So do you need to use some sort of contraceptive? Absolutely. We
Okay.
we all know people who've had like that oops baby at 46,
46
right?
years old. Yep.
Yeah,
Mm-hmm.
yeah.
It
And
happens.
they're like, I didn't
Actually,
think I could get pregnant.
I know a woman, not like one of my best friends, but a friend down the train who didn't even know that she was pregnant
Yes.
for I'm gonna say something along the lines of 6 to 7 months until apparently she was in the shower and her husband looked at her and was like, but she had noted like because she hadn't been getting her period and she had been spotting and it had been kind of all over the place and she just thought she
Yeah.
was smooth sailing, but she was preggers. Just saying.
Yeah. And that's not a unique story. When I was early in my career, there was a woman just like that who came in labor thinking that she had some sort of gastrointestinal
Tummy.
issue going on. Yeah. And she was full term pregnant. And we asked her, we're like, well, didn't you feel the baby moving? She's like, oh, I just thought it was gas. Well, didn't you notice your belly growing? Yeah, I was kind of afraid I might have a tumor or something. I'm like, okay, well, wouldn't you go to the doctor for that, do you think?
No, but I mean,
Yeah.
again, I think when if you have a bunch of kids and you're running around, you're going to soccer and you're doing this and you're doing that and you're not getting your period, just a reminder, a PSA here from your friends at HotPause Health and Dr. Joyce, that you can still get
Yes.
pregnant.
Yes. Yes.
You
Until you've gone the full 12 months with no period. So even if you're on menopause hormone therapy, your period will still stop because of your own ovary function. So, yep.
Okay, that was the best. Thank you for this rapid fire conversation. You are the best. We love you. We're so grateful for you and everything that you do for women's health
Well,
in
I
general.
love what you're doing. I love that this is educational for women because I think the more education women get on this topic, the more empowered they are to take care of their own health care. And I think that's more and more important these
Yeah.
days.
Okay. Okay. Well, we're so grateful for you. Namaste. Thank you
Ah,
for
ditto,
everything, and
ditto.
we'll talk to you soon.
My pink-haired girl and I say aloha.
Did you see the shirt that I wore for you, by
I
the
did. It's perfect.
way? Just for you. Just saying.
Okay.
I actually do think you'd look really cute in this. A little tunic.
Yeah, I don't generally do pink.
No, but you would look so cute.
Okay.
Just
Thank,
saying.
thank you.
Okay. Okay, we'll see you soon.
Okay,
Okay,
bye.
bye.